I know Cami well also, so anyway, very good. Well, so we'll go ahead and start. So welcome to our two best audience people ever. My name is Fred Wu. I'll let my good friends introduce themselves in a second too. But welcome to our session. We're talking about recruiting, training, and kind of retaining advanced practice providers, whether it's PAs or NPs. I'm a PA. I've been a PA for the past 20 years in emergency medicine. I'm at UCSF Fresno, which is the area, as I call, the armpit of California, in the middle. I oversee a postgraduate training program there. I'm also the lead PA for the department. So I'm a past president for the Society of Emergency Medicine PAs. I've worked with ACEP for a long time on this issue. I've served on task forces and stuff like that. So this is something I'm very passionate about because obviously I've been in this for a long time with training, onboarding, and stuff like that. So, but I hope that yeah, you guys have some interesting things, have questions. I think this can be super interactive because there's only two of you here. So if you guys have any questions or anything, I think that's great. And I guess I'll ask one question if you guys don't mind here. What do you guys want to get out of this talk? Are you guys just curious? Are you thinking like, oh my gosh, like the world's coming to an end because PAs are taking over? Or like, do you guys have anything specific you're curious about? Or you go. Sure.
It's kind of hard to navigate, especially in a large hospital system. I mean, I have 100 attending physicians, and depending on who you're on shift with, there's different personalities, different takes. You can pick up different levels of acuity with different people, and it's just a little bit difficult to navigate. So.
Cool. Yeah, totally.
For me, I mean, I'm just starting my career, so I know this is kind of where medicine is right now, and I'm just interested in learning more.
Curious. Cool, okay, very good. And then I'll let my colleagues introduce themselves also.
So just mandatory, we have no disclosures. My name's Sharon Chakijan, and I am an associate professor at Yale, and I have the APP group, which I've had actually for 17 years. So we have 65 people combined between PAs and APRNs, mostly PAs at this point. And we've had this year, when we did this proposal, we decided to talk about, hiring, onboarding, and retention. And we had such horrible retention this year at Yale that I felt like I can't give that part of the talk. That's how bad it was. So we're going to hear about all three of those areas. And I'm going to talk a little bit about hiring strategies because I did a lot of that this last year. I actually had to hire 10 new people out of our whole group, which was really discouraging to me. So I'm excited to hear Fred's talk about onboarding and retention, and onboarding obviously is a part of retention. So if you think back, to when you interviewed, there are various sort of levels, I guess, of desperation on the side of the medical director, right? One is like, oh, I have like the bandwidth to kind of take my time and find exactly the right person. The other is, oh my God, somebody left without notice and I have to fill the spot. Credentialing takes 6 months. Let me just take like a warm body. That's a very bad spot to be in. So I would say the first thing is really just set your mind that it's about talent acquisition. And one of the things that we're actually thinking about doing at Yale is having a pool of people that are kind of ready to go. So it will be like, I forget what they call it, a talent pool. And we do this for nursing. So you have at all times maybe 10 people sort of in the wings that have already onboarded, they're working per diem, everybody knows them, but they don't have a full-time position yet. You could do it with 5 people, but it's great because then you get to pick who you want. They're sort of like in the wings and they're ready to fill in at any point. So this is something mentally, and apologies for my voice, I lost it talking at our social the other night. So this is something that I'm really trying to get like 3 steps back so that I'm not like in that spot where I really have to pick somebody who's graduated and that's my only requirement, right? And it happens, unfortunately, and those folks really don't last that long. You want to be really careful up front. So some of the general recruitment strategies that we've looked at, and I think Fred does this too, I'm sure that Liz does it as well. We really have started to work with, when we see EMTs that are riding along, maybe they're EMT students, maybe they're students from the PA programs in the area that you work with, actually talk to them on shift and say, you seem really interested in this. Would you be interested in a position if we have one when you graduate? And you know who those people are. There are people that are like, they're going to internal medicine, they're going to primary care, they're not excited on shift. But the people that are excited tag them, and that it just means so much, I think, and I don't know if you had that, when you were starting to work, but somebody just saying to you, emergency medicine is for you. Like, I see that in you, and not in a facetious way. I mean, in a really targeted way. You want to really pick out those great people. And this year we have somebody I can think of who was a student with us from the Yale program. We noticed that he was very interested in EM, and we said, would you be interested in our postgraduate training program? Turns out he was, and now he's hired on during this interim 6 months before he starts the program, and then he's coming into the program. So really look around you and see who's there. In terms of when you actually communicate with people, a lot of the communication comes out from HR, and that's kind of problematic because HR is HR, and we're very dynamic people that have very specific things we want from people. So just make sure that the job description that you've written it. HR hasn't written it. Know what your priorities are within the department, what your missions are, your goals are, so that you can actually turn around and describe that to somebody else, right? Because one department might be, we just want you to work and fill in this spot. Another department might say, we want you to be an integral part of our operations group. Another department might say, we're looking for a managerial role. So you really want to know, what your culture is and not mislead people when you get to the interview. I think there's nothing worse than that, I think, is I hear somebody saying, oh, I really want a ton of support when I start my first job, and I don't have that support to give, right? You can kind of see when there's a mismatch. I think you really have to pay attention to that. In the interview, there are always a lot of opportunities to really get to know that person, take them. I think we very sometimes quickly rush through the interview process and really get to know, especially if they have EMS experience, what that experience was like. Start to think about, how you're going to kind of corroborate the information that you've gotten from the interview about whether they be a good fit with you, whether they match up with your mission and goals. And really talk to references that you might have in common. This has been I think by and large, the most indicative of somebody who's going to be great. I always say to them, do you know somebody in our group? Have you worked with anybody? And frequently they'll say, yeah, Liz graduated last year and I worked with her. She was my big SIB in my program, and she said it's great here. I know that person's going to fit in because Liz has already talked to her a ton. She's come to the place where she also thinks she's going to fit in. She's going to have friends actually on shift, which makes a huge difference when you're coming into a really busy department and trying to get organized and oriented. And you really want to make sure, that your whole team is involved with hiring. And this has been really difficult. Sometimes one person thinks somebody's going to be great, another person isn't so sure. I think if you have those sort of discrepancies and you can't sort them out by talking to people who really know the person, I say don't hire them, right? You're going to have a problem later on. Somebody's always going to say, no, I told you this person wasn't a good fit, and they don't invest the time in that person. Once an offer is made, it usually has to go out by HR, by law. You want to make sure you give a warm follow-up so the offer isn't just coming in a letter and then the person doesn't hear anything from the group. As soon as HR says, okay, the offer has been made, you can contact the person, do contact them, okay? Some of the challenges this past year, there's been really slim pickings. We used to not hire anybody without EM experience. But we really have started to hire a lot of new graduates. That's difficult. We haven't had a lot of flexibility in pay, so people come and they want a lot more money than what we're able to offer, and we're really limited in terms of the salary range. And then the other challenge is just what I said, noise from HR. Sometimes somebody at HR might say something or do something that really turns somebody off. I think it's important to really align yourself with HR so that you're giving the same message, and they feel that same sort of excitement from HR as they're feeling from your group, because it can really make people run the other way, and sometimes you'll lose people at that last stage. And with that, I'm going to turn it over to Fred Wu, who's going to talk about onboarding. Any questions? No? You think back to your process, what was it like?
The thing I wanted to add to what Sharon just said too is, for those of you either, already working or soon to be working in the workforce, one of the best ways to find people is to take students, because it's really it's a 1-month interview. So, in my experience, most people can hold in pathology for an hour. That's how you interview someone and stuff like that. But, when you have them for a month, if there's some pathology there, it's going to come out. So whether it's at, 10 o'clock in the morning, 10 o'clock at night, 3 in the morning, if there are issues, it's probably going to come out. So it's a great way to kind of see what they're like. And what she said too about slim pickings, I mean, she's, in a nice, major area of the country and stuff like that. But for some of us in the Central Valley of California, you want to talk about slim pickings, where it's very hard to recruit really anybody to come back. I hope you come back. It's really challenging for us, where we've taken, pretty much a lot of new grads. And we have a postgraduate program, which part of the purpose is to recruit internally, so that if we can, train these folks up really well, and hopefully they stay with us. That's our goal, is when they stay with us. Number 2, they stay somewhere in the valley, which is a super underserved area. And then 3, if they leave us, which is fine if they leave us, they go off and do great things and take our name with them and stuff like that. So that's kind of the slim pickings of living in a very rural area. So, but like Sharon said, oh, did you want to add something? Yes.
I was just going to ask Liz, anything to add to the hiring process?
No, I would say the other thing I would add is just make relationships with local schools, with, and that's an area that we've had a lot of success with, where I now know we have like 5 local schools in Boston, PA training programs, and so I know those directors, and I can talk to them and say like, hey, who are the people in your department who are really interested in emergency medicine? Who should I be thinking of? Yeah.
Yeah, so this year we had a huge issue with retention, because we had a very weird situation that hopefully will never happen to anybody else, where we had an autonomous sort of area built outside of our emergency department without our knowledge, and then we had to staff it. So it was sort of a byproduct of COVID. It was very isolating because our operations team decided to send the PA group there and put the physician out at triage. So instead of having a physician on the team sort of able to, you're able to run patients by them, you're able to talk through procedures, they were completely isolated. So the APP group felt like they were just in a dungeon somewhere. There are literally no windows, and we all work there now. So we kind of redid our operations because of this. And now we have teams, we have residents in that same space, and it's actually working a lot better. But I think it was really the lack of physician support, to be honest with you, and that's something I hope that we will never do again. It was a nightmare for me, a nightmare. Like I lost. Yeah.
And especially in a big teaching institution, we have residents as well, and the residents are newer. They're within 5 years we started our residency program, and there was definitely a little bit of tension with that, because they felt so we got booted out of our trauma center for a while because they felt like we were taking their role and seeing some of the procedures that they did.
Yeah. It's hard. I mean, I'm a big fan of blended teams, to be honest, because everybody has their skill set. Our MD residents really need to learn how to work with APPs, because they're going to work side by side and collaboratively going forward. So I keep on saying blended teams, blended teams. I'm on our operations group, so I try to attend all the meetings, and when somebody proposes something crazy that I already see is going to make a problem for us, I speak up. I don't always get my way. And we did have a problem this last week where we have one PA that's in charge of observation patients, but they were also being tasked with seeing new patients, and it was overwhelming on the overnight shift. And I said, we're going to lose people again. I feel it already. And so we changed right away. And then I checked back in, and everybody said much better. So I think having your pulse on what's going on is important, and having some sway in your operations group is even more important.
Yeah, I'll do this. I think also from a national perspective, just to kind of tag back to your question, is, COVID happened, and I think people kind of saw the beating that we took in emergency medicine, and we're like, yeah, I don't want to do that. That was pretty tough. And also, I mean, just to be honest, I mean, yeah, probably the past 5-6 years, there's kind of been a lot of politics involved with, physicians and PAs and NPs and things like that, that I think probably might have driven some people away from the specialty. I think that's calmed down the past couple years. And I think there's this flexibility with being a PA or an NP, right? Is that, we could do EM for, who knows how long, and then go off and do pediatrics or surgery or, IR or something like that. So we have that flexibility. So that's kind of interesting. So.
But we lost really good people that were like medics for years, and I know it was just it was particular to our ship, but yeah, overall, a difficult couple of years, as you know.
So talking about just onboarding here real quick, or over the next 15 minutes or so. So something that I've done over the years when I've taken on new people and even some of our postgraduate trainees is that, and to kind of give you some background, so there are some guidelines out there that exist already kind of for the use of PAs. So SEMPA, the Society of Emergency Medicine PAs, has some guidelines. ACEP has guidelines. ENA, the Nurse Association, and also AAENP, which is the Nurse Practitioner Association. They also have practice standards and practice guidelines. So definitely check that out. They're all free on the internet, if you want to look those up, and they all have various suggestions on how they should be used and supervised and things like that. So just some quick educational background for PAs and NPs. So PAs are trained in the medical model. It's about 26 months of school, plus or minus a couple months, depending on where you go to school at the graduate school level. And applying to PA school, one of the prerequisites is having prior healthcare experience of some sort. So it's very common to see, people who were, EMTs, ER techs, scribes, physical therapy aides, things like that. I'm a paramedic, so that was kind of my background before going to PA school. And typically it's about a year of didactic training, and then after that it's a year of clinical training, or maybe just over a year or so. And we typically rotate in about, the 7 core specialties. So we'll do, primary care, emergency medicine, surgery, pediatrics, OBGYN, psychiatry. I'm probably forgetting 1 or 2 more, but those are kind of like the core ones there. And then there's currently about 236 programs out there. It's always kind of plus or minus for who's, creating or going away or on probation or something like that. So, but that's kind of like the rough estimate, and it's typically about 2,000 hours of clinical training that PA students get. And then our NP colleagues train in the nursing model and typically go from like the bachelor's to the master's, and then there's a push now to have all programs be at the doctorate level. And they have various practice tracks. So when you train as an NP, you could train as a family nurse practitioner, an acute care nurse practitioner, emergency nurse practitioner, pediatrics, so on and so forth. So there's different tracks for them. And they also have didactic and clinical training. Their clinical training is about 500 hours on average. So, and there's about 350 academic institutions that have NP programs kind of out there. This was a paper put out by my friend Chad and Terry about looking at postgraduate programs. So postgraduate programs are relatively-ish new or so. I can tell you that when I first got out of school, there were only like 3 programs. And now there's probably 50-ish, plus or minus, depending on how many, again, open or close per year and stuff like that. And they're usually 12 to 18 months based on the physician residency model and based on the curriculum of the model of the clinical practice of emergency medicine. So just as an example, I know Sharon has a program at Yale also, but at us at UCSF Fresno, ours is 18 months, and they spend the bulk of their time obviously in the ED, 10 months or so, and then they also rotate off service where they do trauma, anesthesia, ultrasound, toxicology, ICU, things like that. So it gives them a good breadth of training, and they work with our medical students and our residents also while they're on service and while they're off service. And this has really kind of changed things where, if you ever get a chance to work with someone who's done postgraduate training or hire someone, it's really, quite the difference where it's nice where someone else has kind of done the work for you, right? That they have, 12, 18 months of training, of experience already, and then all you have to do is kind of train them on on your local practices, basically. So that's kind of a difference there with postgraduate training. There's also specialty certification for PAs and NPs. PAs have the CAQ, Certificate of Added Qualification. It requires you to have, so many hours of CME, so many hours of practice experience. You have to have an attestation from a physician saying, you've seen these cases or done these procedures. Then you have to take a test. Life is all about tests. You have to take a test. And then that's good for so many years, and you have to recertify that. Our NP colleagues You're required to have national family nurse practitioner certification, again, have so many hours of experience, have so many hours of CME, and then take an exam. Or they could have just taken an academic program or fellowship, like an emergency nurse practitioner fellowship or program to qualify for the exam. So there is some specialty certification out there. I took it, I didn't really change or grow a third eye or like make lots of money all of a sudden. So it's really just kind of a personal choice on, if you want to pursue this or not. Did you do it by chance or?
I did.
Okay.
Actually, our department recognizes it, so we actually get a significant stipend for having it. So we have about 15 APCs, and about 80% of us have our state.
That's it. I'm telling my boss I want a pay raise. So which is nice. And some programs do that.
It's an incentive.
Yeah.
Because you have well-trained APCs in
Mm-hmm.
the department.
Right. Exactly.
One-time bonus or salary increase?
Is it annual? Is the
It's an annual stipend.
right? Okay. Cool. Yeah. And some places do that. So that's not unheard of. And then really kind of the role of all of you out there, as supervising physicians, there's really regulatory and operational roles. Regulatory is kind of very state by state, and you're looking at kind of like the rules and regulations for using PAs and NPs. And the operational role is really how they're used in the department. Okay, so and that could be whether certain patients are seen by a PA or a physician. I mean, or an APP. All charts are reviewed and co-signed. Is there independent kind of practice with some cases and things like that? Now, I will tell you, and this will come back in a second here too, that my personal opinion is that these decisions need to be made at the local site level. I don't believe in some corporate group 3,000 miles away making these decisions for an ED out in the middle of nowhere or something like that. I think it's up to that local site, the medical director, the ED leadership to determine, hey, how do you want to use your APPs? Do you want them to do this or do that or sign charts or not and things like that versus having some mothership somewhere else to decide all that for you. And there's various roles in the ED for APPs, right? So I think traditionally in the past, you've seen folks who have just kind of worked in the fast track and seeing lower acuity patients, and that's really changed over the past 15 years, right? So now we're finding APPs in the main ED, in triage, and OBS units. They could do EMS, right? So it's kind of like the mobile integrated healthcare model where you're seeing PAs and NPs now out on the ambulance or on the fire trucks doing stuff like that. You could be in academics. I know some places that use them as like proceduralists. Because as we can all attest to, procedures take time, and you think, oh great, I'm going to go and do this LP real quick, and then 40 minutes later, you're still in there, and the rack is now 20 deep or something like that. That they have people that just do LACs, INDs, LPs, procedures, things like that. So I think the sky is the limit on how you or your group wants to use APPs, and I think it's really key that when you're using APPs to have department guidelines. Like I was saying earlier, what's been set up locally at the site? What's the scope of practice? Do you want your PAs and NPs to have privileges for intubation or for central lines for LPs or not? Which is totally at that site level. And then patients being seen by APPs, and co-seen with physicians, do you want that done too? I mean, there was a time, so my first job, and you'll appreciate this, my friend from Visalia, so I worked in Porterville actually for my first 3 years. It's in the middle of nowhere. It's a very rural area, and we were a pretty poor practice. So it was our policy that every Medicare patient was staffed with a physician because, you only get 85% reimbursement if, a PRMP just sees it. But if they're co-staffed, then you get the full reimbursement. Well, we were so poor at this site that we needed to collect, every dollar we could. So that was one policy that we did. Are you going to have extremes of age also? So what else are you going to have for PAs and NPs having physicians seeing patients with you? And it's pretty common. This list here is not inclusive, but typically extremes of age, the super young, the super old, abnormal vital signs. If you're going to admit someone, talk to a doc about it. If you're going to consult someone, if you're going to order advanced imaging, if you have intractable pain, things like that. So unscheduled return visits, your bounce backs. That's my personal favorite. I don't know what all of you do, but personally, no matter how stupid of a bounce back it is, I typically talk to someone about it just real quick, and it's usually like a 5-second talk just to kind of CYA and hey, am I missing something? Because those are always kind of biased cases. It's like, oh, it's a bounce back and and stuff like that. Well, it's also one of the highest risk cases you can have out there. So that's my personal practice. But again, to have those guidelines set up of hey, which cases are going to be co-staffed with a physician, because I'm not you guys. I'm not you guys. I know something, but again, I think that's part of the whole team model of, PA-NP practice. Co-signature requirements, again, I don't believe that, all of you as attending should be forced to co-sign charts. I know some groups do that. Some of that might be based on state law, a certain percentage of charts being co-signed. So I would say figure that out, internally at your group level. But to just kind of make a blanket statement and say, hey, Dr. X has to co-sign all these charts, especially if they didn't see in those patients, I think that's kind of messed up personally. So I can kind of see where, you guys would all have that concern of co-signing charts for patients you didn't see. And I don't think that should just be a blanket guideline, personally. That's my personal opinion. I put the doctor title in here just because we're seeing more NPs and PAs getting doctorate degrees. We have a policy in our department that I wrote that they're not going to use that in the clinical setting because it's just too confusing, I think, to patients. It's great you did that. I fully support you going back to school, blah, blah, blah. But in a clinical setting, I just think it's inappropriate, and it just confuses patients on, well, who is the physician, and you have a doctorate and, whatever. But again, I think in that clinical setting, traditionally, patients see doctors as all of you as physicians. Do you guys have anything different that you guys have seen? I mean, in your practice, like, how are you guys supervised?
So we all have one attending physician that is like our attending physician, but it's basically we're supervised by whoever we're on shift with. And usually, so when I put my name on a patient on the tracker board, somebody will hop on with me. And it's usually whoever knows me best or wants to supervise me that day or who has time to do it. Usually people that are comfortable with me. We have a general department rule where ESI 321s are supposed to be staffed all the time. Right.
Yeah, just like that.
Things can get a little, and I think that's where you have to get to know your APCs and stuff like that. I mean, I've had 4s that are missed triage, and I'm like, oh my gosh, we're bumping this up and we're going to chat down about this. I have a low threshold for talking to my attendants about stuff.
Yeah, so that's a great segue actually for like when to kind of get, who needs to be staffed or not staffed and stuff like that. So this was kind of a fun paper that 2 of the co-authors are actually sitting up here. But this was a paper looking at the practice, excuse me, of using APPs in academic EDs. And this was Yale, Mass General, I think Brown, and one more. Bay State in Massachusetts. And just as an example, and it just kind of varies, right? It's wherever you're going to go. So one site was going to had people, everyone was seen by a physician, everyone was co-staffed, everyone except the ESI 4s and 5s, were co-staffed, and that was kind of at their discretion. And then PAs and MPs kind of have some discretion, for when they needed to get someone involved on low acuity patients, that subset. So, as an example, so at our site, where I'm at in Fresno, so we actually have it sounds like what you guys do too, is that the ESI 1, 2s, and 3s have to be co-staffed, and the 4s and 5s, that's optional. Now, if you need someone to co-staff with you, they're there. So don't say that, you're off on your own and good luck, and good, hope you, float and don't sink and stuff like that. But if you're comfortable, if you've been practicing for a long time or whatever, and you feel comfortable, managing this ankle sprain or this cold or whatever, that was at your discretion once you were cleared by the faculty. And we have a process that we usually use, where our new hires go through our new hires, for example, staff everyone for a certain period of time. And then once we're comfortable with them, we discuss it, within the faculty group of, hey, great, we're okay with Fred, being released to, C4s and 5s on his own or not. It just all depends. And again, I think that's good at the site level. So you guys back there, you guys do any different supervision policies on how you guys get involved with cases or anything like that?
Yeah, I mean, I think I met in Chicago and used NP Springer.
Uh-huh.
One PA now. We have a culture that has had a long-standing program. We have, it depends in terms of obviously the case. So anything, generally 4 and 5s are independent. If they can do supervise those that kind of function like a regular physician can co-sign for like 1, 2, 3. And then the other protocol we have is for if you're going to
No, that's a great question. So just to kind of repeat, looking at basically, are we worth it? to kind of sum it down. Right. And then also documentation, you were saying.
Documentation, which translates into coding, which translates into billing, which translates into how do you demonstrate culture, or if you're looking at, say, your finance person or the CFO of a hospital, say you're justifying that.
Totally, yeah. So I would say that for those, Medicare, TRICARE patients where, PAs and NPs see them and get 85%, reimbursement, it's gotten really tricky because the new documentation guidelines that came out, was it this year or was it last year? But the ones that were relatively new, it really changes things. And I can't remember the exact wording, but it's pretty much like, if you co-sign, it's not just co-signing. It's not just saying, I saw the patient, and that's it. It's like you have to do the bulk of either, I think, the history.
Contributed significantly to the medical decision-making history.
And you have to document that actually, because I've talked to, the folks from ACEP who do the documentation stuff, reimbursement, Mike Gronofsky and Jason Adler, who are like the gurus of documentation. It's like you have to chart like the bulk of like the MDM or the history, or I think the physical also, for that to count as, being co-seen or something like that. But you have to actually, you as in the physician have to do that charting. So because of that, like at our site, we don't kind of we don't try and chase that 15% a lot of times because it's just too much for the faculty to do. And we do the same thing, I think what you're saying too, is they do like a resident note for us that, the patient was, seen, with me and we agree with the plan and stuff like that. So it's tricky now with the new guidelines. No, because for the most part, it's the majority of our cases are always staffed, the majority. In the community, so I spent 13 years in the community also, but again, back in the day when documentation was so much simpler, I think it was much easier to try and snag that 15%. And then I think if we got a physician involved, I think at that point, I would say definitely as a physician, you'd want to, chart something that you were involved. As a PA, I'd want to add that, to kind of cover because obviously I had a question about something, and I wanted that to reflect in the chart. So it's trickier to answer your question. And then tracking the worth, there's been a couple papers on this actually, but again, they've been several years. One looked at a PA working in a fast track and found that there was significant value looking at those cases and the billing and the reimbursement and how much came back to them. I can't remember the exact numbers, but there was money to be gained there. And then I know there was a paper somewhat recently looking at productivity, which is how we look at it, is just productivity. And this one actually looked at productivity in a high acuity area of the department. I think they looked at it versus residents and found that, it was interesting, found that the APPs had higher productivity, but the residents had higher RVUs. So from that perspective, my takeaway is kind of like, okay, great, so maybe that's good, but maybe the APPs have like terrible documentation, or something like that. So I think there's some takeaways to figure out, great. Yeah.
We've also found that because there's now so much boarding and patients have such long length of stay, that having, the physicians, see, 2.3 patients per hour, but in terms of our census, right, we have so many other patients that we couldn't actually see those patients without having a team to follow them 12 hours later. So our APPs have allowed us to keep our volume going, and they've been, incredibly valuable in that way as well.
This new documentation requirement at Yale, we were actually rethinking our use of APPs because sometimes it might be easier just to have a second attending in the area. When we actually added a second attending at one of our off-site locations, and it's helped a lot with flow. So I think you really have to look at the mix and how, you can't support 12 APPs at the same time. Maybe now you need to move to having a second attending instead of adding in one more APP. So that's really changed our formula, I think, this new requirement.
And I think it's also super key two, to educate your APPs on the importance and the value of documentation. So when I was in the community, oh my gosh, like this was hammered like to, you can't even believe how much it was hammered. And then having gone to academics now, embarrassed to say that, it's not quite as hammered. But having, them know, great, you want to build like a level 5, hey, APPs, you can build critical care, things like that, where, things get mistriaged, as you said, and it's very common at our site. We don't really have a fast track per se because, everyone who's low acuity gets discharged from the front. So we see kind of, moderate to pretty high acuity. But, we have multiple cases a week of, person in DKA, neck fash, Fournier's, the brain bleed, stuff like that. The asthmatic that looks at really sick but turns around, but those can all qualify for critical care time. Which is obviously, as you guys all know, the highest level of billing that's out there. So I think educating your folks on the billing practices, which I don't think you get. I didn't get a lot of that in school at all, pretty much. It wasn't until I got out in practice that I got hammered on quite a bit. So. And this was an article from EP Monthly a few years ago that looked at one group's method of kind of, doing their supervision policy and also their classification. They had like a junior PA, staff PA, senior PA, based on how much time they were working with the group and kind of like the educational activities that they did to qualify for that level. And the supervision, very similar to what I think everyone said here for the most part, right? So your ESI 1s and 3s, you had to have them co-staffed with a physician. 4s and 5s are kind of optional, although help was there if you needed it. So it sounds like that's kind of like the most common way from what our discussion here is. The onboarding process, the education. So I tell folks that, great, you go to PA school, you go to NP school, you have some great general training, but now's the time to really focus it, right? Because you only get so much emergency medicine training, in a year. So now is really kind of time to, do your education to kind of focus that. So there's lots of boot camp courses out there. There's Rick Bucata's program, there's HIPPO, EM Academy is a program that was set up by SEMPA and ACEP, probably several years ago. I think we've had folks go to a board review course. So whether it's the national one or Ohio or something like that, it just gives you a huge breadth of education there. I really like academic life and emergency medicine. I use that a lot for our new folks and some of our trainees, just because you can assign, they have modules that are all free. It's based on FOMED. You can assign them, you can track their progress. So I'm a big fan of ALEM. And then I also give them a lot of FOMED resources that are out there, right, for at their level. So this is great from CDEM, from the Clerkship Directors Group. They have an M4 and an M3 curriculum. Have you guys all seen this at some point in your life? Or I'm sure you've probably seen this, yeah. But I think it's kind of a nice, segue, precursor that has all these great, super common topics. At the M4 level, the M3 level, there's a PEDS EM curriculum, and it gives you kind of a great breakdown on all the various cases, presentation, epidemiology, management, disposition, things like that. And it's all free, which is what I love here. This is EM Fundamentals. I use this a lot also. It's geared towards the intern level. And you go through there, and there's topic pages, there's kind of the true emergencies, and then there's breakdowns for like abdominal pain and, fever in the infant and things like that. And it links to a lot of FOMED stuff. So, it gives you resources to go, great, you're going to read about belly pain. Here are some other references out there to kind of follow up on that, which is super helpful. Foundations of emergency medicine. Is anyone using Foundations out there at your program? So, oh, okay. So Foundations is out there. Do you guys use it at your sites? No? Okay. It's used that quite a bit, except in this room, obviously. But they have nice structured curriculums for chest pain, belly pain, whatever it is there and stuff. So for example, if you look at like the GI section there, it kind of gives you the objectives. It gives you like, oh great, go look it up in Rosen's or Tintinelli's. If you want some multimedia tools there, there's podcasts or some FOMED resources. So that's really helpful too, where you can, take it and work with a group and say, great, hey guys, let's go over chest pain or belly pain, or have your own little structured curriculum to go through these things. A procedure course I think is super helpful. There's ones put up by SEMPA, University of Maryland has one, HPC, I think that's hospital consultants or something like that. They do procedure courses. And it teaches you stuff like central lines, chest tubes, LPs, paracentesis, things like that, where you can go through on task trainers. Some of them have a cadaver component, which is helpful. If it was my world, it's not, but if it was my world and I had unlimited money, I'd probably have all of our new hires go through some sort of an educational process, whether it's a boot camp or something like that, one. Number two, have them do a procedure course. And number three, have them do an ultrasound course. So that would kind of be my trifecta of training for a new person. Now, if you're in an academic program, I think it's a lot easier to complete those things, right? Because, if you have a program that has an ultrasound fellowship or an active ultrasound program, or if you have, resident conference and they have procedure labs and things like that, I think that's helpful. But if you're in the community, which doesn't have those resources, obviously, I think that, again, that trifecta of education for EM content, procedure course, and an ultrasound course is super helpful. And then kind of going along there for onboarding orientation, I think that, in my opinion, if you take someone like a brand new grad, I think you got to give them at least 2 months, of kind of quote unquote shadow experience. Just because, as you guys know, like it's a hard job, right? So to take someone with no experience and to throw them in there, you really need some time where they can have proctor time, and typically what we do is we stick them with a senior person, a senior PA, where they can kind of work them through cases and talk to them about education and differentials and things like that. Now, to be honest, what really happens is that senior person is probably used for the first 2 weeks, because really that's when you kind of need to know, like, how do I admit somebody, where's this, where's that, where's the bathroom, things like that. And then after that, for the most part, they can kind of just do their own thing, because they're also going to present to an attending anyway. So it's usually those first 2 weeks of learning where things are and kind of how to do things, then you can kind of, make your way through there. And they're kind of an extra person. I put them on when there's plenty of help, okay? Because you don't want them by themselves. You don't want them, during the busiest time of the day if there's not enough help around, because they're just going to be slow. And that's okay, right? Because if I was a new grad and just came out there and was super fast, you'd probably be pretty worried and be like, what's, Fred, missing or doing or something like that. So they're going to be slow. But again, the trade-off is that hopefully they'll stay with you for, a long time, and it'll pay off, at the end there. And you got to evaluate them too, right? Give them feedback and let them know, hey, this is what's going well, this is what you got to work on, these are your numbers and things like that, because they need that feedback to kind of, keep going there. So that's kind of like onboarding in 15, 20 minutes there. I'll turn over to Liz to talk about retention. So.
So in the last couple of minutes, my name is Liz Temin, and I've been the medical director for APPs at Mass General Hospital for the past 15 years. And retention is a big thing at the moment, right? Like, in medical care in general is going through a very tumultuous time, right? There are record physicians leaving, nurses leaving, APPs. We've also had record turnover this year, just because it's become a hard place to work. So I do think we have a lot of levers that we can pull to help retain our APPs. So I'm going to talk about a couple of things here. So the first one I'm going to talk about is compensation. So for the first half of my job, I always thought it was just HR, and whatever they said was the way to go. And I have since wised up and learned that we do have a lot of things that we can do to add. So some of the programs we've put in place, we have a nocturnist program and a weekenders program, whereby if you work 80% of your shifts as nights or weekends, you get $1,000 a month bonus. And we put that in place. I'm trying to put in productivity bonuses based on kind of patients per hour. And then I would say shift bonuses for us have not worked. They've worked if you do it for a set time. So for example, we're covering the residents for their graduation. So, we need extra staffing there. We'll add, $500 or $1,000 to the shift. Or we have 5 people out on family leave for this month overlapping, and so we'll do that. But to do it overall and just say, hey, no one's covering these shifts, we'll add another, an incentive bonus for this shift. Over time, that's actually, we've found that kind of degrades people's willingness to pick up shifts if they're not bonused, or people will wait until the bonus is larger and larger. So we found that in the long term, that actually works against us. But if you do it for a short, specific time, it can be helpful. Communication, of course, is key, right? And so when I had 5 PAs in our program, it was very easy to have monthly rounds and talk and tell them everything that was going on in the department. Now that I have 100 APPs that I supervise, right, that doesn't work anymore. So some things that that didn't work for us, right? So the rounds no longer works. Office hours, we tried having kind of an open door policy once a week or every couple of months. Nobody came, so that didn't work. So the things that we have found that work for us is kind of a multi-prong approach. So we send out emails with important things. We have a monthly newsletter that has kind of learning cases plus pictures of, fun APP things that have been done over the month, plus some key things to look at. And then we also have a quarterly town hall that people can Zoom into, where we, again, go over important things. So kind of trying a multi-prong approach has been the best for us. As Fred and Sharon mentioned, support is really, really key. So a physician comes out of medical school with 5,000 clinical hours. You come out of a 3-year EM residency with at least 13,500 hours, clinical hours. A PA comes out with 2,000 and an MP with 500, as Fred said. You can't expect someone who's come out with 2,000 or 500 hours to be able to just go and see everything on their own or to even know when they need help, right? That is setting them up for failure. And if you saw the plenary session on Wednesday, I think, the ESI process is incredibly error prone, right? So, and as you heard, someone who comes in with a sore throat can be an ESI 4, but yeah, they could have Ludwig's angina, right? And if you don't know to look for it, you're not going to see it and you're gonna miss it. And a lot of the legal cases that I've reviewed over the years are things like simple finger lacerations that missed a flexor tendon issue or, had become a flexor tendon synovitis. And so those low acuity things, even if they're triaged that way, they're not always low acuity. You have to know sick patients before you can safely see those patients independently. So at my shop, every patient is staffed by an attending, no matter what. It also, helps with the billing issue as well, definitely. And as my APPs get more senior and I get more comfortable, I do very little with them. My director PA has been there for 12 years and I trust him with my family. He's taken care of my father and such. So, I don't have to do much. I have to go in and, check that their flexor tendon is working, and that makes me happy. And that's it. Like, it takes me, 15 seconds, but I still do it. And, for the newer APPs, it's really key to be able to talk through with them the way I do with the residents, kind of what are the things to look for. So, as I said, physician-led teams I think is really important. Robust onboarding, as you've heard, is really key. And then ongoing mentoring, because over time, our APPs want to do more, and we're there to help support them, and I'll get into some of the programs that we've done to do that. So recognizing and rewarding good work. Everyone wants to feel that they're valued in their job. And so some of the things we've done that have worked, so we have a program where one of the nurses calls patients after their visit in the ED and reviews with them kind of what was done and any follow-up questions. And one of the things they ask is, do you have anyone that you want to acknowledge? And if it's one of our APPs, our chair actually sends an email to that APP and says, hey, great job with this patient. They said, you were wonderful and supportive. Thank you so much. And that we found has really meant so much to them to have kind of individual feedback on those patients. We also have an APP of the Month award that is nominated by their peers. So they're getting recognition both from the patients and from their peers. And then we have awards at an annual retreat, those who see the most patients, those who do the most education, that kind of stuff as well. And those things have been helpful. As I said, professional development is really key for longevity. And so we have an APP2 program, and I have published on this as well. I don't have the paper here, but you can find it under my name. But for APPs who have been in practice for 3 years, they are eligible for a promotion. They get a shift a month of protected time to do something non-clinical, but something that's brought back to the group. So we have people in our division of simulation, ultrasound, who teach the sexual assault nursing, sexual assault exam, onboarding, operations, and so on, and they become part of the fabric of the department. And then a lot of that benefit is brought back to the department. So for PAs who are work in ultrasound, then for our new hires, they come and do ultrasound training with our new hires. Or simulation, we have a monthly sim session where we do teaching, and they help teach that. So they become kind of content expert in those areas, and then bring that back to benefit our entire group. We have also an APP3 program, and that's more of an outward-looking thing. So for APPs who are publishing and who are teaching on national conferences, they can be promoted to an APP3, and we've actually just gotten Harvard Medical School appointments for those APPs as well. So I think very quickly to sum up, retention is really about feeling valued and feeling part of the team and feeling that you have a place to go with your profession. And there are lots of ways to do that, and I've highlighted some of them here. There are more, but I think it's really key in your program to make sure that people have a process whereby they can acknowledge that they do feel valued and that they are part of it, because otherwise, why are we doing this, right? Like, it's not worth it for the incredible work that we do. And I think that is it. So, sorry I've gone a little over time.
Yeah, so I think to respect the next group that's coming in, we'll step down, but if there are any questions outside, we'll meet you outside. Thank you for attending.